Hello, this is Dr. Pragitya, and this will be a revision for myself and also for some other people that I'll make. So, this is my notes that I have studied, and it is on pharmacology. It is intended for NEET PG purposes, and it is on cardiovascular pharmacology, in which it is on RAAS inhibitors. So RAAS, as you know, is renin aldosterone angiotensin system. So basically, RAAS inhibitors are antihypertensive drugs. So the RAAS system means, as I said, renin angiotensin aldosterone system. So the function of the RAAS system is to increase BP. So if you inhibit the system, the BP will decrease. So that's why it is an antihypertensive drug. So the pathophysiology of the RAAS inhibitors are of this like of the RAAS system is, first there is an angiotensinogen, which is a inactive molecule. It is a protein coming from the liver. It gets converted to angiotensin 1, which is the active form, with renin. And where this renin comes from? This renin comes from the juxtaglomerular cells, or JG1 cells, on the JG1 cells, like the beta 1 receptors present on the JG cells. And these beta receptors, when they receive a sympathetic discharge from the brain, basically when the BP will fall, the brain will send a sympathetic discharge. The beta 1 receptors will be stimulated, present on the JG cells of the kidney, and there will be release of renin, which will convert angiotensinogen, which is the inactive molecule, to angiotensin 1, which is the active molecule. Then ACE enzyme, angiotensin 1 converting enzyme, will convert angiotensin 1 to angiotensin 2. This ACE enzyme is located on the endothelial cells of pulmonary blood vessels. The angiotensin 2 will act on AT1 receptors on many organs, and it will lead to increase in the blood pressure. So, on which organs does the AT1 receptor act? So, the AT1 receptor will act on the adrenal glands, the blood vessels, and the heart. On the adrenal glands, there is aldosterone release, so there will be loss of potassium in blood, and there will be sodium reabsorption happening in the blood. On blood vessels, that is the arteries and the veins, there will be vasoconstriction. And on the heart, there will be cardiac hypertrophy, which is the hallmark for congestive heart failure. And like, if there's hypertrophy, the muscle mass is increasing, so there will be increase in the oxygen demand of the heart. So what are the RAS inhibitors drugs? So there are direct renin inhibitors, which end in iren. So aliskiren is one example. Then there is ACE inhibitors, which end with the word pril. So captopril, ramipril. And there are AT1 receptor blocker, or like more commonly known as ARBs. So they end with sartans. So the most common one is telmisartan and losartan. Then there is also clonidine, which is a alpha 2A receptor blocker which acts on the alpha 2A receptor in the brain. And clonidine, what it does is it reduces the sympathetic discharge of the brain. So it also reduces all the renin release from the kidney. So as we already saw in the pathophysiology section, the sympathetic discharge from the brain will lead to the release of renin from the kidney through the beta receptors on the JG cells. But clonidine reduces the sympathetic discharge, so that's why the stimulation of the beta 1 receptors on the JG cells is reduced, and there is reduced renin release from the kidney. So there is less conversion of angiotensinogen to angiotensin 1, and it leads to less increase in the BP. Then there are beta blockers, which act on the beta 1 receptors of the kidney that are present on the juxtaglomerular cells or the JG cells. So the basically beta blockers, as they act on the beta 1 receptors, so they reduce renin release from the kidney. So it's like clonidine acts at the highest level, that is the brain. Then the beta blockers, they act on the second level, that is the beta receptors on the JG1 cells. Now in in the broad category of the direct renin inhibitors, ACE inhibitors and AT1 receptor blockers, let's study ACE inhibitors. So with ACE inhibitors, there are three mechanism of actions. But first, before reading that, we should know there is a side effect of hyperkalemia with every ACE inhibitor. Okay, now that is out of the way. Let's read on the mechanism of action. So the first mechanism of action is on the adrenal gland, and on the adrenal gland, ACE inhibitors, they decrease aldosterone secretion from the gland. So as the aldosterone secretion decreases from the gland, there is sodium loss in urine, and there is elevated level of potassium in the blood. As we can recall, the angiotensin 2, like it worked by on the adrenal glands, like 80 or worked on the 81 receptor of the adrenal glands by leading sodium reabsorption in the blood and potassium loss in blood. So ACE inhibitors will uh, restrict angiotensin 2 from forming. So what will happen is, on adrenal gland there will be decreased aldosterone secretion, which will lead to sodium loss in urine, and there will be increase in potassium in the blood, and this increase in potassium in the blood will cause hyperkalemia, and increase in sodium in the urine will lead to a diuretic action. Now this diuretic action is not that bad, but increase in the level of potassium, which is hyperkalemia, is life threatening because it can lead to arrhythmias and other things. So whenever we are using an ACE inhibitor, we have to avoid using potassium sparing diuretics, which also cause hyperkalemia. So as we all know, if two drugs, they are both causing hyperkalemia, it is a very big problem, and they are contraindicated to be used with each other. So what are the potassium sparing diuretics which we avoid with ACE inhibitors? Those are SEAT, spironolactone, eplerenone, amiloride, and triamterene. These four are the potassium sparing diuretics that we avoid with ACE inhibitors at all costs. We can remember it with the mnemonic SEAT: S for spironolactone, E for eplerenone, A for amiloride, and T for triamterene. So the second action of ACE inhibitors is on blood vessels. So on blood vessels, as we saw, angiotensin 2 lead to vasoconstriction. So ACE inhibitors, of course, it leads to the opposite effect, that is vasodilation. And the third effect is on the heart. On the heart, angiotensin 2 lead to cardiac hypertrophy, and as we know, hypertrophy is a hallmark of CHF. And if there is hypertrophy, there will be increase in oxygen demand. So ACE inhibitors, it reduces cardiac hypertrophy, so it prevents cardiac remodeling, which is another name for the hypertrophy. And hypertrophy or cardiac remodeling is the hallmark of CHF, as we already read. So that's why ACE inhibitors are the drug of choice for the treatment of congestive heart failure, because they reduce cardiac hypertrophy. Now let's see some examples. So for direct inhibitor, as I said, there is aliskiren, and aliskiren is the only drug which is approved by the FDA as a direct renin inhibitor. in ACE inhibitors, you can say there's captopril and lisinopril, and 81 receptor blocker there is like losartan and telmisartan. We already discussed that. Now let's study about aliskiren. So aliskiren is a direct renin inhibitor, and it directly binds with the circulating renin in the blood. So the renin is already released by the kidney and it is in the blood, but what this drug will do, it will bind to the circulating renin in the blood, and of course it is also an antihypertensive. So the side effect and the contraindication is same as ACE inhibitors. So side effect is you don't you will see there will be hyperkalemia, and it will be contraindicated with potassium sparing diuretics, that is SCAT, spironolactone, eplerenone, amiloride and triamtide. But ACE inhibitor, the one thing it does is increase bradykinins, and we will study about it later again under the section of ACE inhibitors. But for now, we like I didn't discuss it earlier, but ACE inhibitors, they increase bradykinin levels and it will lead to some symptoms we'll talk about. But aliskiren, it doesn't lead to increase in the levels of bradykinin. So let's talk about ACE inhibitors again. So ACE enzyme, is the name is angiotensin 1 convertase enzyme. It is a non-specific enzyme. The enzyme is a carboxypeptidase, and it is located on the endothelial cell surface of the pulmonary vessels. So as we know, the function of the ACE enzyme is to convert angiotensin 1 to angiotensin 2. And now, I didn't talk about it earlier, but now why will there be an increase of bradykinin with use of ACE inhibitors is because ACE enzyme is also responsible for the degradation of bradykinin in our body. So ACE inhibitors reduce level of angiotensin 2, and as there is no ACE enzyme available, it will also increase the level of bradykinin. So let's read what will happen. So increase in bradykinin has an advantage and disadvantage. So let's first see what are the disadvantages. So the disadvantages, it produces a lot of allergic reactions. So the most it is dry cough, angioedema, rhinitis and urticaria. DARU, you can remember it by saying daru. Dry cough, angioedema, rhinitis and urticaria, they are due to increased bradykinin levels in our body. So angioedema is due to ACE inhibitors, and the treatment for angioedema is usage of antihistamines and corticosteroid. If the angioedema leads to laryngeal edema, and which can be fatal, you have to give subcutaneous injection of adrenaline slash epinephrine. It is like the same thing, but you have to give that because laryngeal edema is life threatening. And the other is dry cough. We are not studying about rhinitis and urticaria, but dry cough and angioedema is like the most common. So for dry cough, it is the most common side effect of ACE inhibitor. Like out of the four, the most common is dry cough. The second is angioedema. So in dry cough, the management of dry cough is by stopping ACE inhibitors and by switching over to ARBs or 81 receptor blockers. So basically stop the pills, like stop captopril and other lisinopril and other drugs, and start the sartans. So maybe telmisartan or losartan. But if you want to treat the dry cough there and there, you should give aspirin and iron tablets. So you should give that to promote the degradation of bradykinin. Now, what are the advantage of increased bradykinin levels that are caused due to ACE inhibitors? So, increase of bradykinin will have a vasodilatory effect. So, it will also decrease the blood pressure, and the second advantage is it improves insulin action. So, it is good or favorable effect in patients suffering from diabetes mellitus. So, what are the ACE inhibitor drugs? So, we already know they end with pril. So, there is captopril, ramipril, perindopril, fosinopril, quinapril, benazepril, enalapril, lisinopril, trindalopril, and moxapril. So, let's study about each drug. So, captopril was the first ACE inhibitor to be discovered, but it is not used anymore. Let's see why. So, if you give captopril, it was to be given twice a day, and it is not used anymore because it is the shortest acting drug and it only acts for 12 hours. It is a sulfa containing drug, so it has some side effects, which is bone marrow suppression, disturbance, and like consumption of food reduces the absorption of captopril. All ACE inhibitor drugs are prodrugs. So, like the inactive form of the drug is called the pril, but the active form of the drug will be called prilat. But two drugs which are already in active form, which is captopril and lisinopril. So, as an example of conversion of inactive form to active form, there is enalapril, which is given orally, and as it is a pill, it is an inactive form. But in the body, it will convert to enalaprilat, which is an active form. And this enalaprilat can also be given in treatment of hypertensive emergency as an intravenous drug. But normally it is not given, but only in hypertensive emergency enalaprilat can be given as IV drug. Fosinopril, it is also another drug, and it is also another ACE inhibitor, and it is safe in usage in renal disease, and it does not require any dose reduction because it is excreted in the bile. Okay. Now, the perindopril is the longest acting ACE inhibitor. Ramipril is the second longest acting ACE inhibitor, but it has T half life of more than perindopril. Perindopril uh, has a longer action, even though it has a shorter half life, is because perindopril binds to the ACE very strongly with very high affinity and for a very long duration. So that's why, like, once it binds, it doesn't leave that. The most potent ACE inhibitor is trindalopril. So, what are the uses of ACE inhibitor? As we see it, like before talking about this, what we can see in the notes, we already know ACE inhibitors, they will be good for patients with cardiovascular disease because they prevent cardiac remodeling or like cardiac hypertrophy. So let's study in which all places ACE inhibitors are used. So ACE inhibitors are the drug of choice for essential hypertension. So essential hypertension is basically idiopathic hypertension. So there is no known cause for this hypertension, but just the fact that the patient is having higher than normal BP. Then it is also used if there is hypertension with some comorbidities, like it is the drug of choice for hypertension with diabetes mellitus. If the patient has diabetes mellitus and is hypertensive, the drug of choice is ACE inhibitor. Why? Because drug ACE inhibitors, they improve glycemic control, so they are the drug of choice. They are also the drug of choice in hypertension with nephropathy, like in CKD, because they have a nephroprotective effect. ACE inhibitors have a nephroprotective effect. They are also the drug of choice in hypertension with neuropathy, because they also have a neuroprotective effect. They are the drug of choice in hypertension with retinopathy, because they have a retinoprotective effect. And they are also the drug of choice with hypertension in a patient with scleroderma, because ACE inhibitor also reduces collagen deposition. What is scleroderma? Scleroderma is basically excessive collagen deposition that leads to stiffening of the blood vessels, and ACE inhibitors will reduce the collagen deposition on the blood vessels. So that's why it is also the drug of choice for hypertensive patient with scleroderma. It is also the drug of choice in heart failure, because of course it has cardioprotective effect, it prevents cardiac remodeling, and it is also the drug of choice for a patient post myocardial infarction because of the cardioprotective effect. So, what is the nephroprotective effect of ACE inhibitor? We saw in, like, it is a drug of choice for the patient with hypertension in CKD, right? So, what is the nephroprotective effect of ACE inhibitors? So, suppose the blood comes through the afferent artery of the nephron, it goes to the glomerulus, it and the blood goes to the and the filtrate goes to the nephron, and then the filtrate comes out in the urine after everything, and the blood goes in the glomerulus and comes out through the afferent artery, glomerulus, efferent artery, and the filtrate from the glomerulus will go to the nephron, then it will get more filtrate and it will go to the urine, the waste materials. So in CKD there is hyperfiltration, which leads to albuminuria, so which leads to further damage to the kidneys. So what does the ACE inhibitor do is it dilates the efferent artery. So the efferent artery is where the blood comes from the glomerulus and leaves. So as the blood vessel that leads the blood away from the glomerulus is larger, it will reduce hyperfiltration injury, it will reduce albuminuria, which is happening due to hyperfiltration, and it will also reduce the GFR a little bit, because more of the blood is leaving the glomerulus, because the efferent artery has been dilated and has a bigger lumen. ACE inhibitors are contraindicated in bilateral afferent renal artery stenosis, because in afferent bilateral renal artery stenosis there is less GFR already, which means less production of urine. So if you dilate the efferent artery in this case by using ACE inhibitors, it will lead to more reduction of GFR, which will be a very drastic reduction, and it can lead to acute renal failure or oliguria. So, what are the contraindications of ACE inhibitors? So, ACE inhibitors are not used in bilateral renal artery stenosis. Like, so in a clinical setting, like if you're doing internship or you are practicing, you before giving ACE inhibitors, you can always check the blood supply to the kidney by doing the renal Doppler and check what is the GFR of the patient. Then contraindication number 2, which you always know, is hyperkalemia. So if the potassium K plus is more than 5.5 milli equivalents per liter, And third is pregnancy. In pregnancy, ACE inhibitors and aliskiren and ARBs or sartans are absolutely contraindicated because these drugs they have the maximum risk in the third trimester of the pregnancy. And if ACE inhibitors are used during pregnancy, ACE inhibitors, aliskiren or ARBs, it will produce renal agenesis in the newborns because the RAAS system or renin angiotensin aldosterone system is responsible for the kidney formation in the newborn, and as the RAAS system is inhibited by ACE inhibitors, aliskiren and ARBs, it will lead to renal agenesis in the newborns. So it is absolutely contraindicated in pregnancy. What is the drug interaction in ACE inhibitors? So in hyperkalemia, aspirin, beta blockers, cyclosporin, and potassium sparing aspirin, beta blockers, and cyclosporin can be used, but potassium sparing diuretics cannot be used because ACE inhibitors also cause hyperkalemia, and as we know, potassium sparing diuretics also cause hyperkalemia. So let's see what happens. What is the interaction between NSAIDs and ACE inhibitors? So if you give NSAIDs with ACE inhibitors, it increases the risk of acute renal failure or oliguria because NSAIDs, non-steroidal anti-inflammatory drugs, they decrease anti-hypertensive effect of ACE inhibitors, and the NSAIDs are also they also cause the reduce of blood supply to the kidney. So it is like bilateral renal artery stenosis, bilateral efferent renal artery stenosis. And it also increases the risk of lithium toxicity due to ACE inhibitor increasing reabsorption of lithium from the urine. So what is the interaction with sulfur drugs and allopurinol? So sulfur drugs and allopurinol with ACE inhibitors will increase the risk of sulfur allergy. So what are the side effects of ACE inhibitors? So the side effects of ACE inhibitors are already, as we know, the most common ones: daru, so that is dry cough, rhinitis, and urticaria. There will also be taste disturbance, which is caused by captopril. There is orthostatic hypertension. So for that, use ACE inhibitors and thiazide diuretics. In pregnancy you cannot use, it is contraindicated to use ACE inhibitors. Contraindicated to use in renal artery stenosis. There is hyperkalemia in ACE inhibitors due to ACE inhibitors, and there will be leukopenia or bone marrow suppression due to ACE inhibitors that contain sulfur, so like captopril. So the next part will be AT1 receptor blockers, or better known as ARBs. So I will also cover that in another lecture. Of course this is just for me, but if anyone else finds this useful, it will be good. I'll like that. But that's enough for now. So this was part 1, RAAS inhibitors, you can say, and I've just covered ACE inhibitors and also direct renin inhibitor, that is aliskiren, and the pathophysiology. In the next one I'll cover what is angiotensin receptor blockers. So thank you if anyone is watching.